The maxillary or second division nerve block provides pulpal anesthesia to the maxillary teeth on that side, the buccal soft tissue and bone overlying these teeth, the soft tissues and bone of the hard palate and part of the soft palate medially to the midline, the skin of the lower eyelid, the side of the nose, the cheek, and the upper lip. A 25 gauge long needle is recommended. Following completion of the greater palatine nerve block, the needle is inserted into the soft tissues over the greater palatine foramen. The needle is inserted into the greater palatine foramen and advanced to a depth of 30 millimeters. Following negative aspiration, 1.8 mLs of local anesthetic is deposited slowly over minimally 1 minute. The anterior middle superior alveolar nerve block provides pulpal anesthesia to the 5 maxillary anterior teeth, the incisors, canine, and premolars, the buccal soft tissue and bone, and the palatal soft tissue and bone overlying these same teeth. A 27 gauge short needle is recommended. For the AMSA nerve block, sit at the 9 or 10 o'clock position, facing in the same direction as the patient. The needle is inserted into the tissues at a point halfway along the line between the premolars and the midline of the palate. 1.4 to 1.8 mLs of anesthetic is slowly deposited. The palatal approach to the anterior superior alveolar nerve block, also called the PASA, provides pulpal anesthesia bilaterally to the maxillary incisors and to a lesser degree the maxillary canines, as well as the labial and palatal soft and hard tissues of these teeth. For the PASA nerve block, sit at the 9 or 10 o'clock position, facing in the same direction as the patient. A 27 gauge short needle is recommended. The needle is inserted into tissue lateral to the incisive papilla. The needle is inserted slowly to a depth of 6 to 10 millimeters into the incisive canal. Following negative aspiration, a volume of 1.4 to 1.8 mLs of local anesthetic is administered slowly. There are 2 computer-controlled local anesthetic delivery systems currently available in North America: Compudent, also known as the Wand, and the Comfort Control syringe system. Computer-controlled local anesthetic delivery systems enable the operator to deliver local anesthetic painlessly anywhere in the oral cavity, especially on the palate. The Compudent wand delivers anesthesia at 2 rates, slow and slower. At the slowest rate, a full cartridge is administered in 4 minutes. This rate is used in palatal injections, intraosseous injections, and the PDL. The faster rate deposits a full cartridge over 60 seconds and is used for other anesthetic techniques. The comfort-controlled syringe system has specific pre-programmed injection rates for 5 specific techniques. Both the Compudent wand and the comfort-controlled syringe system have the ability to aspirate via simple controls.
Let us consider the posterior superior alveolar block or injection, sometimes called the zygomatic injection. You'll recall that the posterior superior alveolar nerves duck into the tuberosity of the maxilla, approximately 2.5 centimeters directly above the maxillary third molar tooth. Our greatest problem that we seem to have with the injection is getting into the pterygoid plexus of veins, which lies out lateral to the tuberosity. But there are things that we can do to help us with this. I'd like to show you briefly how we curve the needle with a sterile gauze to keep the needle sterile, so that we can keep close to bone as we approach the posterior superior alveolar foramina. You see I have a gauze square here in my hand, and we just lay the syringe and needle on it, and then I fold the gauze over it so that I'm engaging it with finger and thumb, and still at the same time keeping the needle sterile. And I just give it a little twist here. These steel needles are a little passive so that you can get a curve in them. I don't know whether you can see that or not, but you can see that our needle is curved. And this allows us to stay closer to bone as we approach the posterior superior alveolar foramina. All right, let us show you on the skull now how we accomplish this. I'm going to tip the skull over here just a little bit so you can see a little better. All right, with the mouth half closed and again cheek retracted to get the tissues tense in the vestibular area. And at the time when we're drying the mucosa, we can very easily palpate the malar strut or the zygomatic process because our initial puncture has to be made posterior to it and well out in the vestibule, so that as we curve and carry our needle to the posterior superior alveolar foramina area, we will stay close to bone. So we make the approach, and my needle puncture will be well out in the vestibule and approximately at a level of the second molar. And now if you can watch and see how I maneuver the syringe in an attempt to stay close to bone. I'm carrying it superiorly and laterally so that as we approach the foramina area, I'm going to be hugging the side of the tuberosity so that we stay close to bone and out of the pterygoid plexus of veins. Graphically, we see the position of the syringe and needle bevel at the posterior superior alveolar foramina. In so doing this way, we can stay out of the pterygoid plexus of veins. With the posterior superior alveolar injection, of course, we anesthetize the third molar, the second molar, and the first molar, with the exception of the mesiobuccal root, adjacent bone, and buccal alveolar soft tissues. All right, let's see if we can't show it nicely here on the patient. Again, we're using a retractor, which normally isn't necessary, just so you can see a little bit better. And first we'll dry our mucosa, and you might close just a tiny bit. At the same time, I'm palpating the malar strut. I know where it is, about here at the second molar. And then we'll use a little betadine again, as usual, in our injection site, well out in the vestibule this time. So as we utilize our curved needle, we can stay close to bone as we approach the posterior superior alveolar foramina. We're at about a level here of the second molar and well out in the vestibule, as you can see. Very carefully make our initial puncture. Now I'd like you to watch and see how I maneuver the syringe as we approach the posterior superior alveolar foramina. I'm curving it upward, inward, and outward. And with a light touch, we can actually feel the needle bevel penetrate the buccinator muscle, and we know that we've gone far enough superiorly. All right, we'll aspirate here a little bit. We're in good position. And now we will very slowly deposit about 2 cc's of solution. And this should be adequate for the posterior superior alveolar injection. The posterior superior alveolar injection is a distinct advantage. We'll let Andy close here for just a moment. A distinct advantage where that malar strut lies over either the first or the second molar, and you anticipate instrumentation on that tooth, and it just affords too much of a barrier for a buccal infiltration of that particular tooth to get through, or for the solution to diffuse through. And there are occasions when the posterior superior alveolar block is needed to afford good anesthesia of either the first and or the second molar, depending upon the site of the malar strut in relationship to the particular tooth. We're going to demonstrate on the skull the anterior palatine injection. which anesthetizes the anterior palatine nerve as it leaves the anterior palatine foramen and sweeps forward to approximately the cuspid area on the same side. This again will anesthetize all of these tissues, soft tissues, from third molar to cuspid. We wish to avoid anesthetizing the middle and posterior palatine nerve, since this gives a sensation of fullness to the lateral palate and lateral pharynx, and it creates a situation in which it seems difficult for the patient to swallow. You'll recall the anterior palatine foramen is on a plane anterior posteriorly with the third molar and approximately halfway between midline and the third molar tooth. So we would make the approach with the syringe with the mouth wide open so you can see nicely. And I am just anterior to the anterior palatine foramen in the third molar region, as you can see. And we deposit just a few drops of solution after aspirating, and you will find again that with these palatal soft tissues, due to their fibrous nature, it is difficult to expel solution from the syringe into the tissues, and you have to bring to bear quite a little pressure on the plunger to do so. You will normally see the tissues blanch in this area due to the vasoconstrictor in the solution, and as you observe this, you will know that you have got a few drops at least of solution out into the tissues here just anterior to the foramen. Ideally from a quarter to a half cc of solution, if you can, injected at this site. Now this will anesthetize, as we said before, all of these palatal soft tissues from third molar to cuspid, which would be advantageous, for instance, if you're going to remove a quadrant of teeth and manipulate all of these palatal soft tissues from third molar to cuspid. Now on occasion, you may just be carrying out instrumentation on one tooth or removing one tooth. It is necessary to block the entire anterior palatine nerve, and we can infiltrate just palatally to the tooth in question and so-called get a partial anterior palatine block. Let us suppose we were going to remove this maxillary first bicuspid. It wouldn't be necessary to give the anterior palatine block, but just simple infiltration about a centimeter from the gingival margin on the palatal side of that first bicuspid in such a fashion as this. And again, with a little pressure on the plunger of the syringe, and it does take a little pressure, expel a few drops out into these tissues. Needle bevel is against bone again, and as you see the tissues blanch, you will know that you've got some solution out into the tissues. All right, let us show you the anterior palatine injection on Mr. Fry. And if you'll open real wide for us. Oh, that's great. Now we'll dry the mucosa here first in the usual fashion. Just resting it there for a few moments, and then we'll apply a little betadine in our injection site. And now we'll make the approach with our syringe. Now you can see I'm at about at a level of the third molar. And we make our puncture and carry our needle bevel clear to bone. Then we aspirate, and again in the usual fashion. And then we expel a few drops, up to a quarter of a cc if you can. And I can see those tissues blanching a little bit. I don't know whether you can see it or not, but we are getting some solution out into the tissues, and we know that we have accomplished our mission, and then out quickly. And once again, this will anesthetize all of the palatal soft tissues from third molar up to approximately the cuspid area where it anastomoses with the nasopalatine nerve. We'll let you close for just a moment, Eddie. Now, once again, if we were just involved with one tooth or the instrumentation upon palatal tissues associated with one maxillary tooth, it wouldn't be necessary to block the entire anterior palatine nerve. Let us suppose we were going to remove the maxillary first bicuspid. I'll let you slip your retractor in there again, please. And you might turn away from me just a little bit. That's fine. We dry the mucosa, just resting it there for a moment. And then a little tincture of betadine. right in the area of the injection, just palatal to the first bicuspid. And then our puncture is made about a centimeter out from the free gingival margin on the palatal surface, in approximately that position. And again, needle bevel carried to bone, and then we aspirate. And then with quite a little pressure on the plunger, we just literally need to inject a few drops of solution into the palatal soft tissues. And again, they are blanching a little bit. It doesn't show too well here, but they are, believe me. And that's all we need, just a few drops and then out quickly. And that will allow instrumentation on these immediately adjacent palatal soft tissues of the first bicuspid. All right, we'll demonstrate buccal infiltration of the maxillary first molar. And let's recall in so doing that we'll be anesthetizing both the terminal branches of the posterior superior alveolar nerve and the middle superior alveolar nerve, which anesthetizes the mesiobuccal root of the first molar. And this anesthetizes first molar and adjacent bone and overlying alveolar soft tissues. With the mouth half closed, again, we retract the cheek to create tension in the vestibule, and the needle puncture is made out in the vestibule, and needle bevel then carried to bone. With at least the apex at a level of, or preferably slightly above, the apices of the roots of the first molar. Injection slowly after aspiration of approximately 2 cc's of solution, or those of you that are using carpule syringes, your maximum dosage for each injection is 1.8 cc's, but that should be adequate, and then out quickly. All right, let's demonstrate it on the patient. And if you'll open about halfway for me, please. And we might close just a little bit. That's perfect, Andy. I'm drying the mucosa here now. And then we'll apply our tincture of betadine directly above the first molar. Now you'll notice that again with the cheek retracted, how tense the vestibular tissues are. Out in the vestibule, and I'm approaching the mucosa at about a 45-degree angle, as you can see. Puncture made, carried quickly to bone, and then we aspirate. And then we'll inject a good 2 cc's of solution to anesthetize the maxillary first molar. The maxillary bicuspids are very simply infiltrated buccally, and remember again, we are again anesthetizing the terminal branches of the middle superior alveolar nerve. Just as with the molar, with the mouth half closed, cheek retracted, and our needle bevel is directed towards the vestibule and quickly through the soft tissues, and then needle bevel engaging bone at a level of or slightly above the apex of the bicuspid, whether it be the first or the second bicuspid. All right, let's show that to you on the patient now. This is very similar to the molar infiltration, excuse me, with the except that we're going to change the position of our needle bevel over the apex of the bicuspid instead of the molar. Just close a little bit for me, and fine. We'll dry the mucosa again. And let us show that we're going to anesthetize the maxillary first bicuspid. A little tincture of betadine on the mucosa. Now you can observe again the tight, tense vestibular tissues, and our needle can be very easily passed through them. In fact, on occasion, sometimes you can bring the lip down and actually pull the vestibular tissues over the needle bevel as you make the penetration. And then needle bevel carried quickly to bone. We aspirate and inject a cc.5 to a cc.75 of solution, and then out quickly. Let us now depict anesthetizing the maxillary cuspid, and in so doing, we'll recall that the nerve supply to the cuspid and the incisor teeth is the anterior superior alveolar nerves. Remembering again that the cuspid root is a little longer than are the bicuspids and or the incisors. Labial infiltration, mouth half closed, lip grasped and retracted laterally so the vestibular tissues are again tense and taut. Needle directed superiorly through the vestibular tissues and quickly carried to bone. Aspiration and injection of 1.5 cc's of solution will anesthetize the maxillary cuspid very nicely. Now let's show it on the patient. If you'd open about halfway, Andy, for me, please. And now you might close just a little. Now with retraction of Andy's lip, you'll notice again these tense vestibular tissues. Now we're going to get just a little higher because of the length of the cuspid root. All right, we've made her puncture, and her needle bevel is against bone. And we'll inject 1.5 cc to 2 cc's of solution. And then out quickly. To anesthetize the incisor teeth, again, same technique, labial infiltration, with the mouth half closed, lip retracted anteriorly. Needle bevel can be carried in through the vestibular tissues and quickly against bone at a level of or above the apices of the roots of either the central or the lateral incisor tooth, depending upon the tooth you're going to carry out the instrumentation upon. All right, let's again show it on the patient. Same technique, tissues dry, tincture betadine, through the vestibular tissues, against bone, and aspiration, and again, injection of 1.5 cc of solution will very adequately anesthetize either the lateral or the central incisor tooth. One last injection, and again we return to the palate, the so-called nasopalatine injection. The terminal branches of the nasopalatine nerve, as it's coming down from above through the nasal cavity and terminating from the nasopalatine canal at the nasopalatine foramen, or sometimes called incisive foramen, directly behind the two central incisor teeth. And by anesthetizing the nasopalatine nerve, we will again afford anesthesia of all of these anterior palatine overlying soft tissues from approximately cuspid to cuspid areas, which we would need if we were going to manipulate these palatal anterior tissues in any fashion. As you look in the mouth, you will see that there is a papillae that overlies the incisive foramen directly over it, and we wish to avoid injecting directly into it since it is extremely sensitive to do so. So we find that it's adequate to make the injection on either side of the foramen and or the papillae, and we can very adequately anesthetize the terminal filaments of the nasopalatine nerve. So demonstrating that for us on either side, carried quickly into bone, aspirate, and then again it takes quite a little pressure on the plunger to get some solution out into these fibrous tissues. But again, you will see them blanch as it occurs and know that you've accomplished getting some solution out into those tissues. This is a mirror view of the anterior palatine area, and you can see the nasopalatine papillae right here very, very nicely. We'll dry our mucosa. and apply a little betadine again. And we'll make our injection just on this side of the papillae. It doesn't matter whether you make it on the right or the left, but one or the other. Don't inject directly into it. All right, we have got our needle bevel against bone, and I have aspirated. And now I think as you see, as we depress the plunger, you can see the papillae blanch and the adjacent surrounding soft tissue. So we know that we're getting solution out into the area of the incisive foramen to block the nasopalatine nerve.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.